Let's start the first Osce question. What is thoracic segmental spinal anesthesia? Have you heard of this terminology?
Yes, sir.
The definition thoracic segmental spinal anesthesia.
Spinal anesthesia will be
thoracic spinal anesthesia itself.
spinal anesthesia will be given to a particular segments with the use of non-hyperbaric isobaric due to vacancy.
They have used hyperbaric also.
Yes, sir.
Volume is very low. Okay, thoracic segmental spinal anesthesia is the performance of spinal subarachnoid block at the thoracic vertebral level. So, at what level you would commonly perform this?
At the level of T7.
T7 to T9 is a common, but it can be performed anywhere between T1 to T9. Okay. So it is usually done at as high as T4, T5 or retrograde space between T10 and T11. Both can be done. What are the techniques used for performing this block?
Sir, landmark technique and ultrasound guided.
Very good. So single shot spinal anesthesia or thoracic continuous spinal anesthesia are both combined thoracic spinal and epidural anesthesia, all utilizing long-acting local anesthetic agents like levobupivacaine, bupivacaine, or bupivacaine. Both hyperbaric and isobaric formulations are used. So this is actually the various techniques: single shot, continuous spinal, or both. Why thoracic spinal anesthesia is infrequently used? Why this is not very popular?
Risk of puncturing the lungs.
It's puncturing the lung.
Pleura.
Pleura.
Sir, it blocks the cardiac sympathetic fibers and.
It is injury to the spinal cord and blocking the cardio accelerator fibers. T1 to T4 is the sympathetic supply, isn't it?
Yes,
so if you do a block at T4, T5, it may spread to above and below. So the fear of spinal cord injury, cephalad spread of the block and hemodynamic instability are the reasons for this infrequent use. How is patient selection done for this technique?
Should not have any cardiopulmonary abnormalities.
So usually this is done for patients with very poor respiratory reserve. Okay, so it is the technique which is recommended for patients on surgical and patient factors, and they enumerate the surgical indications. What are the surgeries that can be done for this by using this technique of thoracic segmental spinal?
Sir, so breast surgeries and
Upper abdominal surgeries.
Very good. Abdominal cancer surgery, breast surgery, laparoscopic cholecystectomy, open nephrectomy, cystectomy, cesarean delivery have all been done under this technique. Who are all the patients who will benefit by this? Patients with impaired pulmonary function, as I told you, or a high risk of general anesthesia related complications. These are the patients who are benefited by that. What are the various technical factors to be considered before using this anesthesia? Must identify the vertebral level of dural puncture correctly. Then patient positioning is very important. What is the type of needle you are going to use is very important. What is the drug dosage and drug volume that you are going to give, and the level of sensory motor blockade required, and the duration of surgical procedure. All these things to be taken into consideration. So at which vertebral level should the block be performed and with what volume of local anesthetic? Because we have shown that earlier. So you can do it at various levels. So this picture shows you for colon resection, you can use T4, T5 level. Volume required is 1.7 ml. And the sensory level of block will be between 3 and L5. For gastrectomy, you can insert between T6 and T8. Volume will be 0.9 to 1.2. Sensory block will be at T4 level. Gastrostomy, laparoscopic cholecystectomy, you can do it between T8 and T11, 1.5 to 2.5 ml. And other malignancies. So this picture will tell you the various levels of insertion as well as for the, and if it is breast surgery, T5, T6 level. So you can see the volume is very, very small. And that volume will take care of the segments only. So the lower segments are not blocked. So patient may have a good range of motor power in the lower limbs. So that will maintain the hemodynamic stability. Now, define bad news. This is one of the questions that is being repeatedly asked, breaking the bad news to the relatives. So I thought I will put an Osce on this. What is a bad news?
The news which is unexpected and
So bad news can broadly be defined as information that may alter patient or the patient's relatives' view of the future. Okay, that is how it is defined. So when you say something bad, it's going to affect the future of the either the patient or the parents of the if the relatives. It can be instead of parents, it can be their kith and kin. What are the challenges faced by anesthesiologists in breaking bad news? This is a totally new concept. Most of you would not have read. Am I right?
All the signs of grief can be faced.
All the types of specific challenges are limited preoperative interactions with the family members. Many times we talk to the patient, especially adult patients, we talk to them and explain to them. But we fail to identify the family members and give a small briefing about the procedure and the risk and outcome that is likely to happen. We don't interact with the family members that frequently like we do directly with the patient, and because of work pressure or medical legal concerns. What are the risks to anesthesia personnel while facing this situation? When you have to break a bad news, what is the risk the anesthetist goes through? There are the risk of psychological and professional consequences. You feel very depressed. For example, if you have a death on table like what is reported some time ago about a hospital where a person went for a bariatric surgery and had a cardiac arrest on the table and died. The anesthesiologist would have suffered quite a strong psychological and professional depression, isn't it? So, what is Spike's protocol, which is followed?
We should
You
access
heard of
the
this terminology?
Yes.
So, Spikes is a mnemonic to guide the delivery of bad news.
Reception,
What are all the
invitation.
steps that you have to follow? What are the recommendations of Spike's protocol is? S stands for setting. Determine who will be present during the briefing. Establish whether the patient will participate in the meeting or arrange the meeting for child life presence. That is, if it is not a death, if it is a bad news, you must see whether the person as coming to discuss should have adequate grasping power. Arrange for a private room and limit interruptions. So when you go on to break a bad news, it should be in a private room with no interruptions in between. Second thing is perception. Key for perception. Use open-ended questions to explore what the family already knows. Correct misinformation. Any wrong information already that has reached the family should be corrected. Identify unrealistic expectations from the parents or the attenders. Then involvement. Determine the level of detail that the parents or the patients want. This is supposing you have to break the bad news of a cancer to a patient or some life-threatening disease process identified. That also includes the bad news. It is not only breaking the news of a death with regard to anesthesiology. The morbidity also has to be sometimes revealed to the patient. That also comes under breaking the bad news. So encourage questions from the patient and the comments. Be sensitive to families' culture, race, religious beliefs, and background. So do not try to neglect their views. Then the other part of the mnemonic knowledge. Briefly summarize events to the point. Stop often, confirm understanding. Use non-medical terms and avoid jargon. So don't use technical terms. Try to be as a lay person as possible. Emotion, use empathetic response to family, sound emotional response. And use exploratory questions to clarify the thoughts and feelings and validate response to help the family. And finally, summarize the news, verify the family understands the treatment plan or whatever bad news has been fully understood by the family. Balance hope with realism, set up plan for follow-up. So these 6 things make the so-called spikes protocol for breaking a bad news. Okay. You are seeing 2 pictures here. What is you see in these pictures?
Video version, sir.
Huh? The first picture, somebody is pushing the pregnant abdomen. Somebody is doing something, somebody is doing something. So what has happened?
Left uterine displacement. Reading.
Left uterine displacement. That is done here close
To
up.
prevent the IoT.
Supine
Supine hypotension.
hypotension.
No, this is LUD in close up. What about this picture?
They are doing CPR, sir, in
Appa, that is what is in the first. The top one shows CPR done by 3 rescuers. One doing advanced airway management, second one performing cardiac compression, third one doing left uterine displacement. The bottom picture shows double-handed left uterine displacement. Okay? Whereas here you can see he's doing a single-handed uterine displacement. Whereas this is what is called the double-handed left uterine displacement. Okay? So what are the modifications done during CPR in a pregnant woman?
So fetal monitoring during CPR is not practiced to minimize maternal CPR interruptions.
So try to maintain supine position for effective compression. Do manual LUD and thus doing CPR by single rescuer. Then you can turn the patient to left lateral tilt. That is number 1 modification. Anything else? And slightly higher on the sternum. Because of the pregnant uterus, don't go to the lowermost part of the sternum. So the hand should be on a slightly higher position on the sternum. Quicker compressions, more than 50 compressions. Early intubation. Remove cardiotogograph lead before defibrillation. If the patient is already on cardiotogograph, remove that before defibrillation. Plan for early perimortem cesarean delivery. If the cardiac arrest is not revived within 5 minutes, if return of spontaneous circulation does not happen, plan for perimortem cesarean delivery. How is perimortem cesarean delivery done? What is the other name for that?
It is done within 5 minutes of
Then to save the mother's life when CPR is not able to achieve the return of spontaneous circulation. It is decided within 3 to 4 minutes of cardiac arrest. Its aim is to open abdomen rapidly, deliver the fetus quickly, and close the abdomen fast to remove iodocaval compression. That is the main idea of that. No need to paint and drape. Vertical incision, both abdomen, wall of uterus. Right away deliver the baby as soon as possible. Close by single layer closure. Even if you develop the hernia later on, doesn't matter. You have to somehow save the mother. So that is what is the technique done. And resuscitation will continue during the postmortem cesarean delivery. Will not stop that. And this is also called the resuscitative cesarean section delivery. Okay? It is done more to resuscitate the mother than to deliver a live fetus. So the postmortem cesarean delivery is also called resuscitative cesarean section delivery. Now there is a scenario, a healthy preemie Gavda has undergone a cesarean delivery for breech presentation. During closures, he does suddenly develop severe shortness of breath and desaturates. What are the likely causes?
Amniotic fluid
Amniotic
embolism.
fluid embolism.
Straight away, amniotic fluid embolism.
Blood loss, PPH,
PPH,
postpartum
Iconic
hemorrhage,
PPH.
blood loss,
Yeah.
amniotic fluid embolism.
It can be divided into respiratory, CVS related or drug related causes. Okay. So shortness of breath can be due to any of these things. So respiratory system bronchospasm can be if the patient is a known asthmatic, the hyperreactive airway, or it can be anaphylaxis, aspiration, or pulmonary edema. CVS, undiagnosed pre-existing valve lesions. Many of the mitral stenosis are not exhibited preoperatively. That exhibits during delivery only. And cardiomyopathy, acute hemorrhage, fluid overload. All these are serious causes. Drug-related delayed high spinal laxis like carbopras. Now, I have not included amniotic embolism in that at all. Now, what is amniotic fluid embolism? What are its causes and management? Because amniotic fluid embolism is usually produces a very short shortness of breath and immediately results in a cardiovascular collapse more than a prolonged shortness of breath and desaturation. What is amniotic fluid embolism? What are its causes and management? Entry of amniotic fluid into the maternal circulation via ruptured membrane or uterine vessels down a pressure gradient. That is amniotic fluid embolism. The fetal antigens release lot of mediators which cause intense pulmonary artery spasm, increase right ventricular pressure, RV failure, hypoxia, hypotension, myocardial damage, LV failure, and mortality. So that is the sequence that will happen. Causes are divided into maternal, fetal, placental. These are the three subdivisions. Maternal causes multiparasity, elderly preemie, history of atopy. Fetal causes intrauterine death, meconium later, macrosomia. Placental causes polyhydramnias, tetanic uterine contractions, uterine rupture, and placenta accreta. Management is only supportive and preventive. Resuscitation done in left lateral position to relieve the iodocaval compression. What are tocolytic drugs and what is the indication for their use and their mechanism of action?
Nifedipine.
Drugs which are instilled to reduce the uterine contractions and so that they don't jeopardize the umbilical or placental blood flow and they relax the uterus.
Just now we discussed about fetal surgery.
For the
and
fetal
lot of
surgery.
tocolytic. You
Nifedipine,
want to-
magnesium sulfate, and
We want to
Salbutamol,
treat of
difidipine, magnesium
tocolytic
sulfate.
sertraline.
So they are used to inhibit uterine contraction. Tocolytic drugs are drugs which are used to inhibit uterine contractions. indicated to prevent premature labor in case of uterine inversion or cord prolapse. There are oxytocin receptor antagonists called tocilizumab, calcium channel antagonists like nifedipine, magnesium sulfate, volatile anesthetic, beta 2 agonists like salbutamol, terbutaline, nitric oxide in use of TB. 75-year-old female with CKD stage 3, diabetic mellitus, hypertension, history of vomiting and diarrhea for 12 hours, arrives in ED, develops what are the post-CPR
Pulseless
EKG?
electrical activities.
Hmm?
Pulseless electrical
Yes, electrical activity. This is an ECG taken after CPR.
Bradycardia.
CPS at
Ah,
home.
Bradycardia.
bradycardia. Okay. Anything else?
ST depression, sir. 2, 3
Hmm.
ABF.
AV dissociation.
Ah,
4-degree heart block.
rate is 44, rhythm is sinus, PR interval prolonged, 50 depression in 2, 3, ABF, B5, V6, indicative of lateral wall ischemia, lateral, UPC normal. What are the potential causes of this rhythm? Sinus bradycardia in a sick patient may be due to superior MI, electrolyte abnormalities of potassium and magnesium, or AV conduction block due to beta blocker calcium channel or digoxin and raised intracranial pressure. This is mainly a sinus bradycardia in the sick patient. What is the diagnosis in this patient? Is it due to inferior MI or electrolyte abnormality or AV conduction block? Or
Since he has
raised
history of vomiting and diarrhea, probably electrolyte abnormality.
So this is what is called the BRASH syndrome. Bradycardia, renal failure, AV nodal block, shock and hyperkalemia. All combined together. Okay. So we have all these things in the same patient. That is called the BRASH syndrome. So what is the difference here in the EKG, routine EKG manifestation of hyperkalemia? That the T
Routinely
wave
tall tall T wave will be there.
Tempered T waves are not there.
yeah. So in BRASH syndrome may not exhibit the classical tall T wave or a wide QRS, but only profound bradycardia. So suspect hyperkalemia in patients with CKD. So here is the question, case immediate is given CKD stage 3. So that is the clue. So you have to think of this with the question and in the case history that is given. Earlier I have shown that. So this is an X-ray of rectum excavatum. This
Dextrocardia.
dextrocardia, titus inversus, very good.
Cytosine.
What is this? It's a tube going into the lung with a lot of
Rice
flooding.
tube.
Any tube in right lung, lower lobe.
Right lung collapse with pneumothorax.
Pneumothorax right side, very good. So this is a cardiac fill out you see before and after. What is this condition?
Pericardial effusion.
Pericardial effusion, correct? What is done here?
IVC
Very
visualization.
good. US probe kept in subxiphoid region and longitudinal access to assess IVC size and collapsibility. Very good. How is IVC collapsibility index calculated?
So the maximum average of the maximum IVC diameter and the minimum IVC diameter during spontaneous ventilation or controlled ventilation.
It's less than 5.
IVC collapsibility index percentage is maximum IVC diameter during expiration minus maximum IVC diameter during inspiration divided by maximum IVC diameter during expiration multiplied by 100. Because during expiration, will it dilate more or less?
Dilate
Intrathoracic-
more.
It will dilate more. During inspiration, it will be pressed and minimized. So that is how we calculate. So what information is gained by calculating the IVC collapsibility index?
Fluid
I-
status of the
hypovolemic.
patient.
Sir.
Very good. It's a non-invasive method assessing fluid responsiveness in hypovolemic patients. How IVC pressures interpreted in health and disease using this method? The American Society of Echocardiography recommend IVC diameter less than 2.1 centimeter that collapses more than 50% with sniff, that is sniffing, heat for inspiration suggests normal RA pressure 0 to 5 millimeters. Whereas IVC diameter more than 2.1 that collapses less than 50% with a sniff suggests elevated RA pressure of 10 to 20 millimeters. What is rush protocol?
Rapid ultrasound and
In shock, yes.
Those,
Rapid ultrasound in shock is the name for rush protocol device to find out the cause of shock using ultrasound. So it can be classified into pump failure, tank failure, and pipes failure. Okay. Hypovolemic shock, cardiogenic shock, obstructive, and distributive. All 4 types of shock can be diagnosed using ultrasound. That is what is called the rush protocol. What are reactive oxygen species?
Free radicals will produce reactive oxygen species.
superoxide and
They are a group of highly reactive oxidation state species that are produced by incomplete small film of oxygen molecules. Examples of RVs are, you can say, superoxide anion, hydroxyl radical, singlet oxygen, hydrogen peroxide, and hypochlorite. Okay? So, what are reactive oxygen species? Immediately don't jump to them. The definition is they are highly reactive oxidation state species. What is the role of them in the body? Are they good or bad?
They cause
Because
endothelial injury
damages-
and increases the capillary permeability.
But every day we are producing this within a limited level. Isn't it?
yes, sir.
So it's a double-edged sword in various cellular process. At low concentration, they are critical for receptor-mediated signal pathways and transcription activation. Okay? Abnormally elevated ROS1 is lethal. Cells may lead to cellular dysfunction, induce pathological changes, contribute to development of disease such as cancerous, inflammatory, and neurodegenerative diseases. Among all the reactive oxygen species, which are the most reactive?
Hypochlorite.
Hypochlorite.
Superoxide anion,
Hydroxyl.
hydrogen
Hydroxyl
peroxide.
radical.
Superoxide and hydroxyl radicals are regarded as the most crucial members. Serious threat to chemical integrity of cells due to their high concentration and activity in comparison with others. So the superoxide anion and the hydroxide, these are the maximum number as well as most reactive things.
Tracheostomy.
Tracheostomy tube insecure. What is the purpose of the threads that are taped on either side? Can you see these blue threads here,
Yes, sir.
which are stuck with a plaster onto the chest with a loop? What are they?
To prevent accidental dislodgement of tracheostomy tubes.
Do they prevent that?
Work like a purse string suture and tighten the tuber.
This is called stay sutures. Very good. And they can be used to identify the opening during tube removal and reinsertion. Okay. And they are useful to close the hole after decannulation. So they will just simply tighten that and close the skin wound by using this so-called stay sutures. Okay. Mention few indications for tracheostomy in children.
Laryngeal stenosis due to papilloma.
Long-term respiratory support, clearance of secretion, weak fixed upper airway obstruction. This is how we have to. What is the anesthesia provided for tracheostomy in pediatric patients? Adults, you can do it under local anesthesia.
General anesthesia.
IV said general anesthesia.
Sedation
IV
with
sedation.
LA infiltration, GA with oral or nasal infiltration. Both can be done. How to position children for tracheostomy?
Rose position.
Rose position.
Position in supine in the operating table with the roll placed on the shoulders and neck extended to expose the trachea. In infants and all children, chin must also be pulled up, secured with the adhesive tape to the head to the operating table. So this is how the small infants, then only you will get a proper extension of the neck. Otherwise, the chin will be floating, certainly. How is humidification provided to the patient as a tracheostomy? Commonly, humidification methods include heat moisture exchangers, saline nebulizers, and continuous humidification with a water humidifier in other methods. But here you can have a tracheostomy mask is there, which can bring the heated, warmed humidified fluid. Temperature sensor is also there. So this is how the whole thing. What are the complications of tracheostomy?
Difficulty in vocalizing, especially in pediatrics. Coordination and swallowing and breathing.
Lots of
Tracheal
humidification and crusting of mucosa.
Immediate, intermediate, and late. That is how you have to classify the complications. Immediate within the first few hours, loss of airway, bleeding, pneumothorax, pneumomediastinum, surgical emphysema, esophageal injury, rectal nerve damage. Intermediate, in the first 10 days, tube dislodgement, tube obstruction with secretions, bleeding, infection. Long term, granuloma, vascular erosion, issues with neck skin integrity and tracheal stenosis. Okay, so don't just start enumerating, classify them into immediate, intermediate, and long term. The same in the CKD.
Ventricular fibrillations.
So, the scientist polymorphic V.
Monomorphic VF, not polymorphic. It's a monomorphic. See, there is no twisting on its own. Percentage points are the other way. The monomorphic VF, which should be first treated while doing the CPR or defibrillation.
Defibrillations.
Straight away defibrillation, no CPR.
CPR first.
We have to check for the
Not
pulse.
with CPR while preparing to shock the patient. So what is CPR first approach and what is the evidence in support of this concept? So there are three sensitive phases in ventricular fibrillation arrest. Okay, the first is called electrical phase, which lasts about 0 to 4 minutes. Second is called the circulatory phase, which lasts 5 to 10 minutes. Third is called the metabolic phase, which is more than 10 minutes. So a period of CPR prior to defibrillation may confer a benefit during the so-called circulatory phase of the cardiac arrest. What are the Attributes of high quality CPR reaffirmed in 2015 meeting ECC guidelines. What are called the high quality CPR?
So the heart rate should be 120 beats per minute. We should allow a complete recoil of the chest. The depth of compression should be at least 5 centimeter depth in adult.
ensuring adequate
Venous
rate
access is
100 to 120. Ensuring adequate depth 2 to 2.5 centimeters, not 5 centimeters. 2 inches you will break the bone to 5 centimeters. And allowing full chest recoil, minimizing interruptions to chest compressions, avoiding excessive ventilation. These are the 5 things that have been advocated. Okay, shall we stop here?
Sir.
A lot more interesting OSCEs for the next class. Okay.
Yes, sir.
Okay.